This conference will now be recorded.
Hello everyone. Um, this class is about the introduction of Part 3 exam. Many of you I know that know what is the basic requirements and how is the structure of this exam. But a quick glimpse, and then we will be going to do a good station, that how to approach a general station in MRCOG. So, what is the exam all about? It is what is the nature of the exam? You are just one step away now from a MRCOG degree, which is the academic excellence. It is an OSCE exam, and it is, till the time this time you are well versed with the guidelines that are followed in UK RCOG by the RCOG. Set standard guidelines, nice guidelines, talk generals, articles, all the theory part, whatever is required for appearing in part 3. And now we have to convert this theoretical knowledge into our clinical knowledge, and also in the communication. And we have to be a safe doctor. That is a must requirement to be fulfilled um, by the candidate. And as before, you have given all these tough exams of part 1 and part 2 as well, and we all know that time management is the key to success in this exam. And primary goal, as for all of us, it is to pass this exam. And how can we achieve this goal? um, that also, we know so many things, but for applying it, um, like, keep yourself calm. This exam is a little different. It assesses your whole personality, not your one domain, that's being a doctor and having so much of knowledge, clinical knowledge. Not only that, it assesses you for your for managing the difficult situations which can come up in the clinical scenarios, or in our clinics, in the labor room, in the OTs. So you need to show your calm, or keep your calm, and also just have faith in yourself. Be very, very honest, be very confident also, because you have come this far, so you must be good. So just keep your confidence so high that even if you don't know anything, you are very good in saying that I don't know. And but I will tell you for sure. I will update it to you, to the patient, you can say it like this. And keep your knowledge also updated, and keep your confidence also very high. But there are a number of things which we may not know in our practice, and we have to get time from the person we are interacting with. So in that also, you need confidence. Watch your words. For the patient, you have to use patient's language, I mean layman language. And for in front of examiner, you have to just speak the medical terms, not the jargons, layman terms in that. And in front of patient, don't use medical terms, just use language so that the patient can understand it. And body language should be very, very confident. Practice mindfulness every day so that your eye to brain reflex becomes sharpens, and you are able to process the information given to you at the time of exam quickly and react accordingly. So these basic practices are also very necessary, which we often ignore and think that this exam is only about speaking and speaking to the patient and in front of the examiner. No, there are so many minor things which we have to keep in mind. And we have to improve our personality as a whole for giving this exam, and that will make us complete. And believe me, after giving the exam, you will only become better and better as a clinician, whatever is the result. But your own practice will improve. So this is the, clinical knowledge is very important for passing this exam. An application of what you know and what you don't know, both the things you should know how you will apply. If you don't know something, you have to involve another person, you have to involve senior person, you have to consult the another department, you have to involve multidisciplinary team. So that as a whole, you have to apply your all the senses. And About this exam, we all know that this time it is going to be online, but that you will be having an osler system, and RCOG will take a separate class, or separate. They'll give you time in making you understand the osler system better. How will you interact? How will you open the station? How will you close the station? How will you make the notes? How will you jump to another station? So it will be just on screen, and you will be given 14 stations from all 14 modules. 2 minute time will be given to you for preparation. 10-minute time will be given to you for presenting yourself in front of the patient or in front of the examiner in structural discussions. So there will be, clinical, like 2 golden minutes in which your eye brain coordination shall be perfect. So you have to prepare on that also, along with preparation of the stations and modules, and you cannot ignore that thing for achieving your goal and achieving a great success. Examiners will be, clinical examiner, there will be lay examiner, there will be role player stations and structural discussions. So role player station and structural discussion are almost half now, because structural discussion number have raised. It will include your this thing, general case vivas, risk management viva, your labor ward, gynae ward, this management thing, that will also come in structural discussions. Then there will be teaching station. In role player station there will be a lay examiner also, so those will be 4 to 6 approximately, role player station, where there will be lay examiner. They are not medical teachers, or they can be totally unrelated to medical department, and they can be anyone, like lawyer, any social service provider, so like those. So they will only be assessing you about your communication skill, and those lay examiner stations are really having more marks than the simple uh, examiner station and the simple SPTs. So the SPTs which involve lay examiners, they carry more marks and they give you the bulk of this, and they are easy to or marks are easy to obtain in these stations, because your communication skill which you have already developed in your clinics, this you just have to refine, and you have to present yourself, and you have to talk to patient, make her comfortable, so that the lay examiner can assess you whether this patient would like to come back to you or not. So, based on your communication with patient skills and applied clinical knowledge, also like how you convey the things to the patient, and does the patient understand? And do you keep this patient safe? And do you provide not like, are you able to convince the patient about her diagnosis? So these are the things, that a lay examiner see and give you marks upon. And you will be tested for the 5 domains that I'll be explaining you. And there will be asterisk points, which, people are very worried, like what kind of asterisk points that we should pay attention to in the RCOG examiner key. What are those points that we should cover in the station? So what I think, if you know the basic template, if you know the basic patient safety points, if you know the communication with colleague points very correctly, if you have the exact knowledge about the station, or even if you do not have the exact knowledge, some stations, that can pop up like you have never seen that, but if you have a background basic idea, and you can involve your colleagues in that, you can communicate with your senior, and you know how you can convince this patient, and you have all the patient safety points on your fingertips, and you try to manage those, putting those points in your template, in your that station, then those are the asterisk points. The main patient safety points, like assessing the patient for venous thromboembolism, assessing the clinical governance points like Jehovah Witness, that you cannot miss asking the patient any blood transfusion reservations. If she's a Jehovah Witness, then you need to ask. You cannot miss that. So these are the points which you need to remember in that station. Like a placenta accreta station has come, and you don't ask the patient about whether she has any restriction to blood transfusion, what is her blood group. So If you miss those things, then those are also the star points. Okay, so these are the asterisk points. So rather than bothering about those 5 6 points, you have to include all the important things in your station so that you do not miss any. And the domains, which are 5 domains in that, patient safety domain is the most important. Like the ICOG says you for how safe a doctor you are. And then comes the just excuse me for a minute. Yeah. So then comes the um, communication with patient. In patient safety, that is the most important, I've told you. Then the communication with patient, this is like it comes with your clinical practice. And the and also otherwise, you have to just practice what else you yourself want to understand as a patient. If you or your family is a patient, if any of your family member, if they have any condition, how would you like to make them understand that condition? And we all know what level of I mean a non-medical person in our family, how far we have to go to make them understand that this is the thing. And we have to convey it in the similar way to make our family member satisfied with our answer. Similarly, we have to make our patient satisfied with our answer. So we have to practice and practice on our communication skill for this. And another thing is information gathering. It should be very targeted, very crisp. We cannot keep on asking here and there questions and take long pauses, or keep on putting open questions, many open questions to the patient, just one or two open questions. And then just make a frame in your mind, make a block in your mind about what points do you should highlight in your imagination, immediately, that what points you want to ask from that patient. And you have to just quickly go through those points, very important points. And also you cannot miss the patient safety points, which I'll be talking about in the next slide. Then applied clinical knowledge. You, whatever you know, you need not to tell everything to the patient. It is just that you have to give the patient enough knowledge about the condition which is required at that particular point. That you cannot like, as if a oncology patient has come, a cancer has been diagnosed just now, so you will give the time to that patient to assimilate the news. And at the same time you will be arrange a MDT meeting for her, and you will give just a brief idea about how you can go about this cancer after proper staging of the cancer. So at this stage, when you just do not know what all this cancer can be, you are not going to explain her the steps of radical hysterectomy, or any radical treatment, or the side effects of radiotherapy right now. You just have to give her a glimpse of what all can be offered to her, what is the treatment, but it will all depend upon the investigations and the staging of her cancer. So, this is the applied clinical knowledge, that you have to make a strategy before telling her. And this strategy making, you will be very fast in making a strategy once we will be practicing for the exam. And then communication with colleague, this is the simplest domain. If you include it in your this thing station, you will be given extra marks for this. I mean, the marks which have been decided for communication with colleague. So never forget to involve the GP, because patient is in close loop with the GP first, and then patient comes to you. So always involve GP. That will be one part of communication with colleague you have to include in all the stations. Even if GP has not referred you the patient, still you will inform the GP. Okay, because GP will be interacting with the patient first on the community level. And then other departments, whatever you are involving, you should justify. Like, if you are involving a physician why you want to involve. If it is a case of cholelithiasis or obstetric cholestasis, eh, and with liver dysfunction, do you want to involve GE specialist, then why you want to involve that also you should be telling the patient. And now, coming on to the various domains, in patient safety, first of all, checking the identity. Like you need to check that makes you a safe doctor. That are you talking to the same patient you are supposed to? Is this the same patient? Because in our outdoors also, you must have noticed that we first check the name. That are you this patient? Okay. Then we check it. Then we have to check it on the prescription or on the station, right? The station has been provided to you, and you have to check the name and age of the patient and match it with the station in front of your eyes. Then you have to check in patient safety points. There are many safety points. One first of them is checking the identity, then asking the patient for any important history, like history of any drug allergy. Drug allergies are very important to ask in each and every station throughout the 14 domains. And even if in teaching domain you have to teach your student and involve the you have to mention allergies, that whatever you are teaching, the student should also be able to exclude the allergies in the patient. And then VT risk assessment makes you a safe doctor. If the patient is having pulmonary embolism and VT risk assessment has not been done, or yeah, so that makes you unsafe. So that will be giving you a negative mark. So apart from that,
This conference will now be recorded.
okay, so VT risk assessment, as I've told you, and then if there is an underage girl, then you have to check the Fraser and Galley competencies. So this is again a big patient safety. Competence is a must to give consent, or to communicate also. And if there is any PPH station or any retained placenta or any shoulder dystocia, then you should know that you cannot deal with it alone, and you have to call for help as a first and foremost thing. And then you need to involve your seniors. Documentation is also a must safety part for any medical personnel. So, right investigations for the right patients. You have to check the identity along with the investigation also. That is this the same investigation for this person? And follow-ups, appointments are also very important for the patient. You need to tell the patient when to come. If suppose there is a CIN patient, and you have done a procedure leap, you have done, then you need to tell her that to follow up for the reports, and follow up for regularly, how frequently she has to get the pap smear done. And also checking for the blood group, geo witness, incident reporting. If some incidents has happened, like major PPH has happened, more than 1.5 liter blood loss has is already there, then you have to do the incident reporting. And also wherever, like in a retained swab, or wherever it calls for, we need to do the incident reporting. That is a very important patient safety point, which is there in the RCOG forma as well. So coming to the information gathering in this, the because we have to be really quick in this, like in 3 minutes we have to finish up with the history, targeted history. So just quickly build a repo, just introduce yourself, okay? Be neutral. If you don't know about the station, like is it a happy station, is it a breaking bad news station, just be neutral in all the station. Build a repo with the with the humble uh, hi hello. And then maximum one or two open questions you have to ask that patient, okay? And make a frame, as I already said, make a frame in your mind, that what all questions, like if any bleeding question, you will ask about the pain related with bleeding. Or if she has bleeding, did she pass any clot, did she has cramps also along with that, and since when she's having bleeding, how much pads, how many pads she is using, changing. And uh, ever had these kind of problems before? Has she had any treatment before for this, and any investigations have has she undergone. If she says yes, I have got this investigation done, okay, are you aware of the results? Okay, what are the results? I would like to review your notes. And these all, typical 1, 2, 3, 4, 5 question from question, and then finish that particular symptom history, related symptoms that can be that you need to ask. Pain in abdomen, if there is pain, is it radiating to shoulders? Is it associated with any dizziness? Suppose she's pregnant, so you have to ask, rule out the ectopic pregnancy in early pregnancy. So any urinary problems, any bowel problems, so this all a lower down area you will cover. And then any surgery overall in the body, not only in the tummy and the lower area, just overall anywhere in the body, that did she had any surgery. And apart from that, uh,
This conference will now be recorded.
so in this, be a good listener while she is,
This conference will now be recorded.
so be a good listener. Just the moment when you are asking the patient, if she says anything, just do not overlook any complaint which she need your attention at that particular time. Okay, like always keep on saying. Non-verbal communication is also very very important in this exam. Like if she is saying anything that I'm having a lot of pain and it is troubling me since very long, then you say, oh, I see that. I'm very sorry to hear that. Yeah, I can see you're really having a stressful time. Oh, but I'm here to help you. Yeah, okay. And can you tell me if it is related to this? Okay. All right. And what other things that you found? Like this, you just have to keep on promoting the person, as well as you need to ask, give a very empathetic feel that you are a very good listener. You are understanding and you're paying attention towards whatever she is saying to you. So never be like, okay, do you have pain? Okay, since when do you have pain? Where it is radiating? Okay, so if she is complaining of pain to you, first and foremost thing that you need to start with is, oh, I'm sorry to see you in this situation. Do you wish me to give you something, some medicine to for the pain? Because I want, that I want is that you should be fine as we start talking, and you should not be having this much of pain. So first make her comfortable, and then you start saying your all the story or asking her the history. Okay, so that will build a rapport with the patient, as well as patient will understand that this is a caring doctor. And
This conference will now be recorded.
so then in the end of the information gathering, you have to summarize. If you don't have time to summarize, do not worry, but just add one liner that, is there anything else you want me to add in this? Because if there is something in the script which you haven't asked, then the patient may tell you at that time, okay, yeah, I had this problem in the past. So, like that, you just must ask after every history taking, that is there anything else you want to add? And um, you may get benefited. Then in communicating with patient, as I already said, great, proper and clear introduction. Patient should know your role with her. And in breaking bad news, don't be smiling or too happy. Just be neutral and give review of your strategy to the patient. Always appreciate patient for good things, like as if she is you know she has done something to improve her lifestyle, like if she is reducing weight, or if she has reduced alcohol. Tell her that, okay, this is a good thing, a very good thing. And then, yeah, it will be better if you will do it more, or reduce it more, or if you don't take it at all. And then you can add 1 or 2 points also, that this can affect your own health as well as baby's health as well. That's why I'm concerned, but as you're already on your way, so I really wish I really appreciate you. And also there are few societies like in NHS stop smoking services, and there are alcohol also. There are services which can help you to stop alcohol. While so there are helpline numbers I can provide to you. So like this you can go along with the patient and also clear your point as well. Open question one or two are good, not more than that, because then patient will keep on saying and you will not be having enough time and you will start having panic that when she will stop and you may make mistakes. So always ask one or two open question and then keep on asking your own template or own, not on template. Template means your own strategy or strata of questions which you have thought at that point. And don't ignore any queries however and whatever time they are taking, you have to solve their query and give them time to think. Sorry. So communication with colleagues will be involve other specialities and refer whenever it is required, justify your referrals and keep your DDs, and that's how you can involve other specialities if you know the DDs differentials of every situation. And applied clinical knowledge, apply your own knowledge, stepwise application of the knowledge to the patient, like do not impose each and everything and involve the patient in decision making. Do not give your opinions, do not impose your opinions till the time it is asked or chosen. So just give option, let patient choose. In every station, in every management station, give options to the patient that is there anything you particularly want from these treatments? These can be your options. Is there anything which you want to know? So like that will you know that will spare your time as well as you the patient, whatever the station demands from you, you will get to know that. So both ways you are in benefit. So structural discussion, we have already discussed that there will be case vivas, risk management vivas, information leaflets you should know recent guidelines, GTG, NICE, last 5 years are very important, and that you can, you will go to the RCOG website, and there in the box you have to type guidelines, GTG guidelines, and ascending or descending, you put descending, so the newer guidelines will come first. So, like that, you have to search the RCOG website and keep on visiting the website frequently and watch all the strategy videos. So, this is about like brief of MRCOG part 3, like what I think is um, really to be paid attention for. And now there is kind of a station you can read it and we can start with it. If anybody want to play the station or do the station, you can raise your hand in the chat box. Yeah, and you can read it in 2 minutes and then I'll start a timer of 8 minutes. 10 minutes, sorry.
This conference will now be recorded.
Yeah. Okay. So yeah, you did very well. I really appreciate that. So now, from my own perspective, I've given you your feedback, but overall, you did well. So I don't have anything to say. Apart from that, now how I will do it, like it is my template, not yours. First of all, you have to make it sure, okay? And do not follow me. I say it again and again, do not follow me. Follow your own path and make yourself better by the, if you like something from someone, just take that point and make it your own version, because you are yourself, like you're unique. I have been taught a lot, but in the end I spoke what I liked to speak, and everybody want to take credit from your success, but that's their right also. Like if they have taught you something, then they can ask for the credits. But in the end, we all know that we all are different, we all take the teachings differently. Until the time, you cannot speak anyone else's words and letters and win the race. You have to make your own draft, own document. So own way of talking you have. So that's why, from the same person, if the same person is teaching three or four people, and one or two get succeeded, two are not, so that means that the version which has been perceived is different for all of them, and they have applied it differently. Nobody can taught you so well that you can pass this exam. This is your exam, so you have to be unique and be yourself. First of all, just make it your version. Okay, I'm just giving you the glimpse and idea how to follow the basic things and put all the basic things in uh, one station. So see here, as soon as I see the station, it will be almost everything for all the stations. Like, it will be everywhere for all the station. The information gathering task, communication with patient, communication with colleague, patient safety, and is applied clinical knowledge. So these five tasks you will be assessed for in all. So what is my advice is to practice all station with all these five contents. Yes, so even if they are not asking you to communicate with colleague, you involve your colleague in your station. That will give you extra mark, or extra impression that this person knows that at this place she need to involve the colleague or the senior. So that's no hassle in adding it. And here, as I see, I know that I'm an ST5 here. Cover, and you'll be ST5 only because there you are. They are expecting you to be in this level, intermediate level. So of registrarship. So you are covering the early pregnancy assessment unit. So I have to tell this to my patient that, and I have to be oriented to the early pregnancy assessment unit. So in introduction, you have to add this. So your role and the place. These two things are the utmost important. This shows your orientation to the time and place. You're about to see your next patient referred by GP. So you have to this mention GP also in your introduction. Evaluation of an early pregnancy assessment unit of your hospital. Details are given below. What are the details? Patient's name. So just keep it, scan it in your eyes. And Gemma Splates, 25-year-old, called in today complaining of a brownish. Today she called in with complaints of brownish vaginal discharge and not feeling pregnancy symptoms again. UPT taken today has come positive. So urine pregnancy test has come positive today. So you now you know the complaints briefly from the GP letter. You know that this patient has come to you, referred to you for these complaints, and she is a pregnant woman. 25 years is the age. So at 25 years, I'll not ask about the smears, because smear starts after 25 years. So that's a borderline. Like on 25th birthday, they get a call. So um, then then I'll be like, okay, now I'll start it. So in this, okay, I forgot. Okay, yeah, I told you that this is a missed miscarriage station. Ultrasound report is showing missed miscarriage. So in this, mm, just be neutral. Tell your name. Hello, I'm Dr. So and so, working as I'm your doctor today in the early pregnancy assessment unit. May I confirm your name and age, please? Then she'll say, I'm Gemma, I'm 25-year-old. Always ask, how would you like me to be addressed? How would you like to be addressed? Or how would you like me to call you? So that she will be giving you permission of calling her by her name or calling her by Mrs. So and so or only Gemma. So that will be patient's choice, never your choice. So always take permission from the patient, or if you do not take permission, then be formal. Call Mrs. with surname. Okay, here it is Gemma, 25 years, so you ask her name. If any elderly woman is there, you can say Mrs. surname. Okay, like this you can greet. So I am Dr. Kaur. I'm the doctor on duty here in early pregnancy assessment unit. May I confirm your name and age, please? Yeah, okay. And how would you like me to address you? All right. And you can call me whatever your nickname, or how you can call me Jatinder, or you can call me Jeet. So, as I can see, Gemma, that you have been referred by the GP because you have some sort of problem today, like a discharge coming out. Yes, doctor. Okay, and some urine test has also been performed on you for the pregnancy. Are you aware of the results? Then ask her before declaring the result. Take the idea always, okay? She'll say, yes, I know I'm pregnant. Or if she says, no, I don't know. Okay, in that situation, what I do is I'll ask you a couple of questions, and then I may send some investigations for you, and then we can talk about your condition and we can make a suitable management plan for you. How does that sound? Yeah, okay, doctor. Or if she, or anything else you, any concern, any other thing you want to add? Then if she has something that is really bothering her, she'll speak up now. So, after making confirming the purpose, you ask yes or no, agreed, take a pause, then make your agenda. Ask agreed or not. If she want to add anything, and as in this condition, in online exam you will be given ultrasound along with the station, because there will be no one to give you the this thing, add or edit the document in the station. So they will already be giving you the ultrasound scan that will be showing a missed miscarriage, or GU sac is there, in which there is no baby. So you have to break the bad news in this thing, two steps. Warning shot one, which is always and always being given in the beginning, if you know that this is a breaking bad news. So you just ask her, Gemma, do you have anyone else with you, or have you come alone? Yes, doctor, I have come alone. Okay, actually, I have a lot to discuss. Do you want your partner to come? Um, no, that's fine. So you have told her that you have a lot to discuss, and if there is anyone else, that would be better. So you have given a warning, kind of a thing. And then if she want to call, it's okay. If she doesn't want to call, she'll not call, obviously. Then you start with your open question. So, okay, Gemma, can you tell me more about your condition? Then whatever she has to say, she will say that I am having this discharge or anything, whatever she is having in her script. Okay, Emma. And if she knows about the pregnancy, you start asking her about this pregnancy. And if she doesn't know about the pregnancy, you ask, when did you have your periods, Emma? Okay, this many time before. And were you having your regular periods? Yes. Okay. And do you ever got pregnant before? That whatever she has to say. If she says yes, then you take the past pregnancy details. If she says no, then you carry on with this situation onwards. Okay, so you had your periods 8 weeks ago. Do you have any kind of nausea, sickness? Have you consulted anyone for this delayed period? No. By any chance, can it be a pregnancy? Then she'll say, yes, this can be. Were you planning for that? Or if she says, I know, she knows that she is pregnant. Okay, did you plan the pregnancy? If she says she doesn't know about the pregnancy, so you say, were you planning for pregnancy? She'll say yes or no. Contraception, what contraception she was using. If she says I was using condoms, okay, that's a very good contraception method of contraception. But I would like to tell you or give information about many other very reliable forms of contraception which you can use along with condom to avoid such kind of unplanned pregnancies, because unplanned pregnancies, and those will be better to use. So just say, but after this pregnancy, we'll discuss about that. Or later we will discuss about that. Then if she knows she is pregnant, are you taking folic acid? Since when you have discharge? Is there any tummy pain, any bleeding, any fainting, dizziness? How's the water works? Bowel upset, intercourse, any investigations? Blood so scan. Now you know that it is a missed miscarriage. No need to ask about intercourse, because of miscarriage also she may have bleeding. Like a crisp history you have to take. Then smear STI if she is 25, more than 25 years. And um, then medical history, you'll quickly be taking about hypertension, diabetes, asthma. It is important to take. Then allergies are important to rule out, blood group and blood transfusion reservation. And then surgical history, family history, social history. You'll quickly ask, if I can ask you, do you smoke at all? Do you take alcohol? Any drugs in the past or now? Okay, and how's the support, Jim? Okay. Do you feel supported at home? And do you ever feel low down or distressed in the recent past? No? Okay. And in the and before also, like in few years or back then, did you ever have any mental health issue? Then she'll say, okay, yes or no. Then, do you feel safe at home? For ruling out domestic violence, you have to rule out in each and every woman in obstetric station, in gynae also. And examination is not required in online exam. Then, regarding investigation, you need to check about the full blood counts, blood group, and ultrasound. You have ultrasound, so skip that. Blood group, if patient says skip that. Full blood counts, yes, you will offer her. Then one liner for PIL for all the condition. Like in this missed miscarriage thing, you will be explaining. Now you will be giving a warning shot. You know that will be um, warning shot 2. So here, in the beginning of the applied clinical knowledge, after the investigation you have sent, then you say, okay, Gemma, after going through your investigations, I can see that, and after talking to you, I can see that I have confirmed your name and NHS number. You have to confirm the identity on all the investigations, okay? And I've seen your investigations and I've spoken to you as well about your symptoms and condition. So I can see that you have I don't have a good news for you, Gemma. Uh, I can conclude that you have a condition we call in medical term missed miscarriage. That means, simultaneously speak, that means that pregnancy has stopped growing inside and there is no baby inside. So we call, either you say this is a missed miscarriage, that means pregnancy stopped growing, baby is not forming in this pregnancy, baby is not going to form in this pregnancy if there is no baby. And if there was baby, there is a baby which has no fetal heart and it is a missed miscarriage, then tell that baby has died inside the womb. You have to make it very, very clear that now this pregnancy is not gonna survive. So just say the pregnancy has stopped growing inside. We call this condition in medical terms missed miscarriage or missed miscarriage, which means this. Then give a pause. Then let her react in her own way, whether this was a planned or unplanned pregnancy, welcomed or not welcomed pregnancy. She will react in her own way, that can vary. Sometimes you can quickly say, okay, we never wanted this, you just tell me how we can go about it now. So you have to explain the methods. Otherwise, if she's mourning, she's very upset, then just give her time, just ask her whether she would like to get a pause or she want to reschedule. Do you wish to me to reschedule this appointment? Do you wish to call your partner? Shall we stop here? Just these one liner within 10-second gap you can ask the patient. I can see this is very distressing for you. Yeah, I can see that, but we are there, Emma. We are there to help you. Then she'll ask why this has happened to me, or even if she doesn't ask, you say 2 out of 10 can have this problem, and this is usually a one-off event. Like there are high chances of having a you know normal pregnancy in the next time whenever you conceive. Now, do you wish that I shall explain you how we can go about this now, or you want me to book another appointment? Then whatever she is, she will be asking you, okay, you tell. Then you have to give choices to her first. You tell her that, these are the methods. Gemma, what we can do, we have few options for you at this stage. Like, we can just wait and watch that pregnancy will cause it take its natural course and expelled by its own. Or another thing is medicine. We can give you a set of medicines and that can help this not growing pregnancy to come out or miscarriage to come out. Another option is having an operation that will be in one sitting, single sitting, and uh, one day event. So, what is there any preference you have, or you want me to tell all the options in detail? Then she will be like, if she want to ask about medicine, she will ask you. So you tell her the complete medicine part. If she want to ask you surgical evacuation, then she will ask you about the surgical part. Or expectant, if she is too much distressed, if her script says that be too much distressed and don't ask anything, let doctor handle your condition, then you have to say, you have already said that there are these options. Do you wish me to explain you any preferred one, or you want me to tell you all the three? Yes. Then if she says any preferred one, it's okay. If she doesn't say any preferred one, then you say, okay, Dema, I will explain you all the options, and also I'll be giving you written information so that you will be having a better idea about it. And what I'll do in the end, I'll book you a joint meeting with your partner and with my consultant as well, so that if you have any queries, we can talk about it. Yeah. Does that make some sense? Okay. And also I'll write to your GP so that GP will also be knowing your condition better. And yeah. So Gemma, in expectant management, what we do, we just it may take 1 to 3 weeks in starting of the process and naturally expulsion of the miscarriage, and we call it silent expulsion also. But sometime the bleeding may continue for long, like 3 to 6 weeks, and there are slight chances of having a infection also, and you may feel pain. So you must need to have some support at home. We advise you that. Yeah, okay. Um, I know, Gemma, it's hard for you to know all this suddenly, but I'm sorry that you are facing this situation. Wherever you feel that I need to stop, just don't hesitate for that, okay? And from this management, 50 out of 100 women they successfully get the termination of pregnancy. Another method is medicines. A set of medicines will give you, and that will start the process in which you will be having pain and sometimes vomiting also. So we give you a paracetamol tablet for pain relief and also anti-sickness medicines for whom 85 out of 100 women they successfully get this medical termination. Good thing is that there's no operation and no anesthetic risk. But yes, the prolonged bleeding, pain, and infection that can be there. But we advise you after any of the method you opt that you get the urine pregnancy test at 3 weeks to be sure that pregnancy has all been removed. Yeah. Another method is operation, in which we put you to sleep. Anesthetic doctor is involved in this, and a plastic tube is passed through the neck of the womb, and sometimes the neck of the womb is tight enough, so we put some medicine to make it relaxed. In the morning, we admit you on that day, and then through the plastic tube, the pregnancy tissue, the miscarriage thing that is being removed. A 95% success is there from this method, but 5% still fails. So after this also we advise you to get a urine pregnancy test done. Am I clear so far? Is there anything you want me to repeat, or you want me to be more focused on? Okay. Thank you, Gemma. I wish to see you soon, and once you go home, if you have more bleeding or pain, or any foul smelling discharge, just come up quickly to the emergency. I'll be giving you a 24 by 7 contact number. Yeah. Okay, and also, Gemma, these kind of conditions, they can put, they can put distress on you. So it's better to, consult a counselor if you wish. You and your partner may join. Yeah, I can book the appointment if you want me to. Yeah, please don't hesitate to ask for any help or support from our side. Thank you so much. So, like that you have to just be in the station, be next to the role player, like she's your own patient, and your aim is to counsel her completely, and also fulfill all the required asterisk point or important points that you can fill. Yeah. Why have you asked the blood group and blood transfusion reservation? Because she is a miscarriage, she may need the blood transfusion also. Okay, partner you have to involve, consultant you have to involve, safety netting you have to do. Any patient, any patient in obstetric, whoever come to us, even in our clinics, in whenever we admit any patient and we discharge them, if they are ANC, they are early pregnancy, then we write at the end of the discharge letter that in case of any bleeding, pain, discharge, report back in the emergency, right? Similarly, in every station, ANC, obstetric, you have to do the safety netting that makes you safe. Yeah, because patient may not be knowing it. She will say that today only I have gone to doctor and she has said that everything is fine. You'll be offered methods, many methods they have told me, and now nothing will happen to me. So even if she is having bleeding, she may think it's all right. Doctor has already seen me. So she may be in a pool of blood and she may get anemic, and she'll come in, in a bad state in the emergency. So you just have to do the safety netting every time you see a patient. Every time. In gynae also, in ops also. So this is how you end the station, and keep on covering the important points like writing to GP, documentation. I did not add in this because or I added, I forgot that I will be documenting our discussion in your notes, okay? And I'll be informing the GP as well. So keep everyone in the loop, and documentation makes you safe. Information leaflets makes you safe because any information which you forgot to give, information leaflets will give. And GP is involved, counselor is involved. Next successful pregnancy chances, you have tried to resolve her and this, maybe she's worried about it, that why this has happened and this can happen next time. If she ask or she doesn't ask, just make her hopeful that she will be having a good chances of a normal pregnancy. So this is how we generally go towards any station in preparation. um, so summary is, be yourself. You are unique. Don't let anyone dull or overshadow your sparkle. If someone says speak like me, don't follow that. If someone says speak with me, don't follow that. Make your own thing. You are a clinician. You are a full-fledged working consultant in your country or a postgraduate, whatever stage you are having. You are whole soul in yourself, and for giving this exam, you are doing so well. So better learn to be yourself and watch RCOG videos again and again and learn their pattern, how they talk to their people and how safe they are, and so that you will practice all those things in your pattern and make yourself a version of the required standards. So practice the Lisa Joyle, Oxford, Tony, get through. These four are enough, and Justin Conji also have good stations. But if you do all these four, I think this is enough. And recalls are very, very important. Last few 5 6 years recalls you must do, so that to have an idea. Sometimes they are repeated also in the same way. And learn the layman language. There are phrases to use, words to use. Um, the templates are there in many groups, so you can use that. And for the medical, no, do not use medical terms in front of the patient. Do not mix the things. So with this, I end this meeting here, and I wish to keep more and more sessions with you guys. If you want another session on any specific module, just message in the chat box, and I'll be looking into this and we can soon be together again. Thank you so much for your time.